Okay, we're going to go ahead and get started. If you guys want to make your way back to the table, that would be great. Just a couple reminders is the drawing basket for our prizes at the end are on the corner of Region 4 South, that red basket up there. So if you did not enter your name, that's where that's located. And then if you did not sign in at the registration table, please make sure that you get your name noted on that sheet just so we have an idea for head count. With that, I'm going to turn it over to Sue with NAMI here. Sue is Executive Director with NAMI and has joined us several years at this event. So she's going to be doing a legislative update, and then we're going to move into our consumer and our legislative panel at that point. So welcome, Sue.
Sure. Good morning, mental health advocates. Okay, there's going to be legislators here in a little bit, and they need to hear your voice. So good morning, mental health advocates. All right, much better. So I'm going to quickly go through what happened during the 2024 legislative session. As always, things happen. As you know, I say that our mental health system isn't broken. It's never been built. We never had a system, and that's what we're doing. And so every year, we try to actually improve and build on our mental health system. So one thing happened is we didn't have as much money this year as we did the previous years. Last year, we got about close to $100 million, new dollars for mental health. There wasn't as much money to spend, and that's especially true for the Health and Human Services committees. At the very end of the session, instead of having a Health and Human Services bill and an education bill and a transportation bill, they had a megabus bill, and everything was in there. It was literally 1,492 pages long. And I did read every single page because we wanted to make sure that we knew exactly what happened this session. So we ended up with about $25 million for mental health, not as much as we had hoped. And strangely, there was almost 11 million that was actually appropriated a year ago, and the Department of Human Services didn't get the money out the door. And so normally it would have gone back to the general fund, but luckily the chairs of the committee said, no, we're going to keep it in mental health. So we were at least able to keep that money, but it was frustrating that the department hadn't gotten it out the door. And so the money that went into there was CMIG, which is the Cultural Ethnic Minority Infrastructure Grant, money to help people get their supervision for free as they're becoming a licensed professional, our mobile and tribal crisis teams. We wanted to have locked residential facilities, especially for people who are deemed incompetent to stand trial in jail. That money didn't get out the door, so it got kind of reappropriated, but at least to mental health. So one of the big things, in Otter Tail County is going to get $250,000 of this money, thanks to Senator Rasmussen, and you've heard me talk about this before. So the hardest part is when a family member calls me and they say, I can see my loved one is struggling, but they won't go to treatment. And they call the county, and the county says, until they're a danger to themselves or others, there's nothing we can do. We now have something we can do. And so what the Voluntary Engagement Project will do, and there'll be an RFP, a request for proposal that will come out, is that you could actually send out a peer specialist, for example, to work with that person every day for 90 days to try to get them into treatment voluntarily. You'd look at them holistically. Do they have insurance? Do they have a provider? Do they have housing? They can work with the family to say means restriction for suicide prevention. Do you know how to help your loved one when they're having delusional thoughts? And we really think that we could really change it up by doing this voluntary engagement. So I'm very excited that Otter Tail is going to be one of the counties that's going to do this. And whoever it is that's going to carry it out in this room, please come talk to me about what that vision is. Also, we want to see if we can use Medicaid funding for the first episode of psychosis programs. We have 5 programs in Minnesota. We need at least 8. But I'm going to be honest, with the legalization of cannabis, we know that we're going to see more episodes of psychosis, and we need to have more programs to really help these young people and do an intensive treatment for them. We also wanted to make sure that the community support programs included clubhouses under that funding stream. Some counties were saying, oh, if you're a clubhouse, you're not a community support program. We're like, what? No? So we just changed that to make it sure. And they're going to look at Medicaid funding for clubhouses and community support programs as well. Occupational therapists are now added to adult rehab mental health services. They play an important role, and now they can be part of that team as well. The first episode of psychosis programs, they can actually decide that someone is eligible for an assertive community treatment team. You might say, well, who cares? The reason we care is that when you're in a first episode of psychosis program, we're preventing hospitalizations. But to get into an ACT program, you have to have been hospitalized. And we're like, okay, again, doesn't make sense. So we tried to have this make sense. There's a new commitment task force. There had been one back in 2013 about when we commit someone as mentally ill and dangerous. You know, people end up going to St. Peter, and the average length of stay there is about 8 years. So we're trying to find out, like, are there ways that we can get people out of there faster? What are those community services that we need? We've met twice already. I'm on that task force, and we're going to really try to figure out how to reduce those barriers to folks. And then for intensive residential treatment services, IRTS programs, they're trying to reduce some of the operating burdens. Some of it just didn't make any sense for small programs. Some of you might have heard about the 48-hour law. This is where someone is in jail, they're deemed incompetent to stand trial, then they're committed, and they're supposed to be moved to a state-operated program in 48 hours, which doesn't happen. And you have to remember that this is a problem not only in Minnesota but across the country, because the number of people who have been deemed incompetent to stand trial has gone up dramatically. So 10 years ago, around when this law was passed, we had a lot of people from community hospitals and a couple of people from jail. Now the only people who get into ANOCA or the security hospital are people from jails. No one from hospitals can get in anymore. So it's an issue that we need to address. So one is that now there's criteria for how you get in. So it isn't just that you've been on the waiting list the longest, they're really looking at who needs it the most, okay? Because some people are not as sick in the jail as others. Also, we want to help get people treatment while they're in the jails. So there's going to be a demonstration project where the state will actually pay for psychiatric medications, including if someone needs an injectable, they'll pay for the nurse to go there to administer it and see how that goes. We also are trying to create these locked IRTS facilities because, again, Anoka's a far away from here. So what if you had a locked IRTS facility up here, right? Because we don't, someone might be not safe enough to be able to leave the facility when they want, right? And the judge is not going to let them go anywhere else. And so we want to have these kinds of programs around the state so people are closer to home as well. And then they're trying to expand the capacity of our state programs as well so that people are moving through there faster so that we can serve more people and get people out of the jails as well. On children's mental health, we got $3 more million for School Linked, which actually wasn't enough because the previous biennium, they increased the dollars, but then the next biennium, they decreased them. I'm like, that doesn't really work very well. But we got $3 million back up, and that School Linked is where the money goes to a community provider who co-locates in the school. And we're so worried about our kids right now that it's really important that these programs, frankly, are as robust as they possibly can be. We got an additional $2.6 million for respite care. Respite care is for when a family needs a break. I actually used to do respite care for families of kids with disabilities and mental illnesses in Hennepin County. The family'd come on Friday night. Frankly, they looked like hell, right? They were exhausted. They were just so tired. And whatever they wanted to do over the weekend, they could do, right? Sometimes they would just sleep. Sometimes they did laundry, went on a date with their spouse, paid attention to their other kid, and they'd come back Sunday night, and they were refreshed. And we know that when you're not as stressed, you can handle more. And respite care actually prevents hospitalization of kids because families can bounce back and really care for them. We also want to make sure that we expanded who got respite care. So if you lost your in-home services, you probably need respite care, right? Because you're not getting those services. Maybe your kid was stuck in the ER. That means your kid probably has high needs. We need to make sure that you get them. If you use crisis services, let's make sure those families get it. We have a children's crisis residential program in statute, but there's no funding for it, so we want to see if we can get Medicaid to pay for that. And then for parents whose kids were in residential facilities, they had to pay a fee. And, it just seems kind of unfair, honestly. And so they got rid of that, which I think is really good because that was another barrier for families, and it was a lot of money. This is kind of a little bit more, insider stuff, allowing flexibility with the functional level of care assessment. You get to choose which one you want to use. It's allowing medical assistance for psychoeducation for both the family and the child, and on the same day if they're served separately. Because that was really a problem. It's like, well, the kid would come in for psychotherapy, and then the parents would have to come in on a different day. And it's like, no, it's 2 separate services, same day, and especially when transportation is an issue, this will make it so much easier. And then here's the thing that's been, you can't file, a child in need of protection just because a parent has a disability. And so we want to make sure that we're offering supportive parenting services so that child can remain with the family. On the criminal justice side, one thing that was added is they can't provide excited delirium training to law enforcement. Excited delirium is a made-up term, okay? And unfortunately, it's been used a lot to restrain, especially people with mental illnesses, and we've actually had people been killed because of excited delirium. So it doesn't a thing. We don't want police officers to think it's a thing, so they can't do that anymore. There's a thing on the federal level called an 1115 Medicaid waiver. And what all this means is that you can bypass some of the rules of Medicaid. And so what the legislature wants to do is to have the Department of Human Services apply for a waiver so that when people are in jail, that they can actually access Medicaid 90 days before they're released. It'll actually help people in prison even more because it's a little bit easier to know when they're going to be leaving the prison. But this could help in terms of making sure that people actually get the medications that they need in the jails because Medicaid will pay for it. And then another thing which is now going to be it's going to be very controversial at the legislature this session because of things happening in Minneapolis. But they raised the age of delinquency for children from 10 to 13 to go into effect in January of 2026. And the reason is that 10 and 11-year-olds are not competent to stand trial. They don't know how to work with an attorney. They don't understand how judges work, right? And so what would happen is they would be deemed incompetent to stand trial, and then they'd actually have to drop the charges because you can't charge a little kid. So, but because of things happening in Minneapolis, I'm not sure this is going to come back for sure this next session. On the education side, schools have to create a cell phone policy use. They can decide what to do, but they have to have a policy. And I think we've seen that in some schools, they've said, no, you can't use your phones during the day. And, I think it's actually just knowing, frankly, some of the negative impact on kids of social media and using their phones all the time and, frankly, kind of being addicted to them. Kids in schools get bullied a lot through those phones. And so this, we want to kind of create that safe space. You don't want a picture taken of you in the bathroom and all those kinds of things. So I think it's kind of a good policy, but again, it's up to the districts. They have to offer eating disorder awareness for coaches, which makes a lot of sense because we see a lot in sports, whether it's girls or boys, eating disorders kind of come up. Think about gymnastics and some of those other things. And so it's good for those coaches to be aware, again, for that early intervention. Also making it easier to access telehealth in schools. Sometimes people are like, where do these ideas come from? They're from personal stories, which is why I'm really looking forward to hearing yours after I'm done talking. So we actually had a dad come to us, and his daughter had a therapist, was going to do telehealth in her school, high school, during the day, and they said no, she couldn't do it, and they weren't going to offer her a room or even an empty room to do it. And we're like, well, why not? So now in high schools, if there's an empty room, you got to let a student have access to their therapist through telehealth, which just makes sense. And in high school, you don't need someone else with you. Elementary school, you might say, yeah, but in high school, you don't need that. And then they're requiring mental health education in grades 4 through 12. Now, you might say, that's a great idea. Here's the problem. There's virtually no curriculum for teachers to teach mental health education. And so we're a little worried about that because we had problems before when we talked about suicide prevention, that what was being taught to the kids was actually promoting contagion because people were sharing all the details of their story, which you're not supposed to do. So we're a little concerned about this. We've reached out to the Department of Education because we want to make sure we have classes that are actually approved to make sure that we're doing this the right way. Now school resource officers, or SROs, originally they weren't allowed to use prone restraints. Prone restraints is when you're on the face down. It can be very harmful to kids, depending, and well, adults too. It's something that's banned, frankly, in schools, but the school resource officers didn't like that, so now they can use it. And the post board, the police officer training board, is creating some standard policies, which is actually up on their website right now that people can comment on. There were some issues last session allowing school social workers to bill Medicaid for special ed students, so they kind of fixed that. And then they're going to have a study group and do a pilot on addressing school truancy. Since COVID, we know school refusal and truancy has gone way up. And a lot of it is actually related to anxiety, especially for the little kids. And so what we don't want is putting those kids, frankly, in child protection or truancy, because we need to address their anxiety. So they're going to look into this, which I think will be helpful. On the healthcare side, every hospital system has to do what's called a community health needs assessment. But if you tried to find it, you would have a difficult time. But now they're going to offer more transparency. A couple years ago, we looked at all of them across the state, and there were usually 3 top healthcare issues. Guess where mental health was? Number 1 in almost every single one. And then we'd look at, so what was their plan to address the mental health needs in the community? And it was, I don't know, pretty small efforts, right? Like, we will do a public awareness training. Well, that's not access to treatment, right? So we need to see what they're saying and to be able to comment on it. Now, this is a great one. If you have private insurance, no prior authorization for outpatient mental health or substance use disorder. None. And that's great, because that was a huge barrier depending on what health plan you had, right? So it's like, that's what you need, you get to go. You don't have to do anything. And they can't also apply that retrospectively. The other thing is that say you have to get prior authorization for a certain healthcare condition. Unless your healthcare condition changes, you don't have to keep doing prior authorization. And so that just continues, which again has been an issue. Another interesting thing is that if they deny services by saying, like, say you were approved for residential, and they say, no, or you applied for residential, and they said, no, we think you can actually do intensive outpatient, that will now be considered a denial that you can appeal. Before it wasn't. They're like, no, they offered you services, even though it wasn't the right level. So these are important things to remember if you're dealing with private insurance. And don't forget that we now have a mental health parity unit within the Department of Commerce who's really looking for these issues. And then if a hospital is going to close an inpatient unit, which includes mental health units, they have to give a 182-day notice to the community. On housing, this was one that we worked on. Some of you might have seen the article in the papers. So in the city of Anoka, when the police would go out to a 911 crisis call, and if it was mental health, they would write down the information about the person, the medications they found and things like that, and then they would send it to that person's landlord and encourage them to evict them. I am not kidding you. Because, you know, information that's collected by police is not covered under HIPAA. And so we now passed a law that's like, no, you don't get to do that. So if you call 911 in a mental health crisis, you can't be threatened with eviction or any other punishment by the landlord. Because we don't want people to be afraid to call 911, right, when they need it. So it's just an important thing to remember. There's also a work group that's going to look at how can we simplify access to supportive housing. Has anyone here tried to get like affordable supportive housing? It's kind of a nightmare, right? I mean, there's lots of different programs, and it's hard to figure out which one you're going to apply for. So they're going to try to simplify this. And then the other thing for the Minnesota Housing Finance Agency, again, housing programs, if you are eligible because of your income for things like food stamps, then you're going to automatically be eligible. So you don't have to keep filling out tons of paperwork for everything when your income has already shown everyone that you're living at or below the poverty line. Now, there's some things under Human Services. So if anyone has medical assistance for employed persons with disabilities so that you can work a little bit, right? You don't have to do a spend down. You just pay kind of a monthly fee. You don't have to get redetermined all the time. So they're going to really extend that out. Min choices is what you have to do to be able to get a waiver, like a caddy waiver, so all those in-home services. And it used to be that the assessments, you know, they had to be like 60 days. Now it can go up to 365 days. So it can go a year, which is really going to help. Like, say someone goes into the hospital, right? They've never got, you know, it's just going to speed things up. And as we all know right now, like, people complain about kids boarding in the emergency room. Well, if that child, they're like, well, maybe that child could get a caddy waiver. How long does it take for them to get that assessment? It's often 6 months. And so, you know, you're not going to leave the kid in there for 6 months, but they need those in-home services. So we're trying to speed that up. Now, NAMI's worked a lot on sober homes, and that's become controversial. We've been told by the Sober Home Organization, why would anyone call NAMI? And it's like explaining that half of the people with a substance use disorder have a mental illness. So yeah, people are going to call us. And while there are good homes, and these are an important part of our system, there's bad ones too. And we've gotten those complaints, you know, where it was not well kept, you know, and things like that. But the biggest problem that people had with mental illness is that they weren't allowed to use their medications, even if they weren't addicting medications, right? So that was a problem because they were like, no, you can't use any chemicals. Well, if you have schizophrenia, you might actually need that medication, or if you have bipolar disorder and things like that. So now they'll have to make sure that people do have access to their medications. Assisted living staff, a lot of people with mental illness are going into assisted living programs and have zero training on mental illnesses. Now they have to have training on mental illnesses. It was actually hard fought to get this, but it did get in there. And the other thing we found is that people who are older and on the elderly waiver, so they didn't get on a waiver until they were over 65, had a lot, and they had a mental illness, weren't able to be discharged easily from a hospital, because the cap of dollars on the elderly waiver is a lot lower than, say, the caddy waiver that most people with mental illness use. And now there'll be an exception so that we're not leaving people stranded in the hospital and not able to move out to get the care that they need. Now, there's a couple things under commerce. So one is that if you wanted to get long-term disability insurance and then you needed to use it because of a mental illness, you didn't get to stay on it very long. Most of the policies had a limit, only for mental illness, no other illness. And you wouldn't even know that. So now they have to at least disclose it. We wanted to get rid of that discriminatory factor, but we didn't win. But at least you have to know that that policy you're buying isn't going to cover the illness that you have. And we thought that was important. You might remember that last year we changed the life insurance policy related to suicide. So it used to be that if you took out a life insurance policy and you took your own life within 2 years, your family got nothing except the premium back. And then we lowered it to 1 year. We got there. We wanted to lower it more, but we couldn't do that this year. But there was some old language in there, like if someone was sane or insane. I'm like, we really don't use those words anymore. So we were able to clean up that statute. And then it's going to be illegal to deny medical care due to medical debt. And so we've had that happen in like clinics and things like that where someone owes some money, you know, maybe they've gone through a hard time or something like that, and then they're cut off from treatment. And that's also not okay. So that's also going to be changed. So 988, as we all know, is a really important part. And so last year we actually said, yes, we can do a telecom fee that goes onto your phone in order to pay for 988. Now they've set the fee at 12 cents. So we're lucky. We're one of the, I think it's only like 7 or 8 states that actually have the telecom fee to pay for 988. So that's a good thing. And then they're just really trying to streamline the certification process for children's mental health providers. When you're providing more than one service, they'd have to go in for like each one. And so they're just going to streamline that to make it easier. Rates. Everyone wants to know about rates. Does anyone in the room think that we pay our mental health care providers what they should get paid? Do we cover the costs, the plain costs of delivering mental health care? No. So we got some more money this session. Last year they were waiting for the Department of Human Services rates report. So it came out in February. it showed clearly like some rates for some services should be increased like 200%. That's how much we were not paying for the actual costs. So we were able to get a couple things. One was $5.7 million for hospital inpatient mental health and substance use disorder care, which is important. We know our inpatient psych units are called loss leaders. They, Medicaid doesn't pay for it. The other thing to remember is that Medicaid is the main source of funding for mental health care, not private insurance. And so that makes it harder for providers because you don't have that balance between private insurance that pays more and Medicaid. Substance use disorder treatment, 3% raise. And then for mental health, and this gets complicated, they put $1.6 million for 2025 and $8.4 million the next biennium to increase the rates for mental health to be 83% of the Medicare rate. I know, it's like, it's hard to understand for sure, but at least there's some, but we need to keep going more in order to keep our places viable. And we are seeing programs close around the state of Minnesota, which we don't want to have. The other thing we wanted to look at is that some grants maybe shouldn't be grants. So take our mobile crisis teams. Every county is covered in the state of Minnesota. Why should you do a competitive grant, right? It takes up a lot of time for you here, right, in this region. It takes a lot of time at the Department of Human Services to read them all and grade them. So instead, we want to actually move to a formula so that it would just, the money's there, it would just go out based on population or things like that. So they're going to be looking at that between now and the next session to see if we can come back with a formula. The other one would be like school linked, right? We don't want to rearrange the deck chairs on the Titanic. If you have a really good school-linked mental health provider, why would you take money away from them and give it to someone else just to add a new program? So we need to create stability within our mental health programs. On the workforce, they repealed the limit on physician assistant scope of practice. Before this, they were not allowed to diagnose and do the initial treatment plan for people with serious mental illnesses, such as schizophrenia, bipolar disorder. The Board of Social Work and the NASW is creating an alternative pathway instead of taking the national test. When you look at who was not able to pass the test, it was largely, frankly, men and people of color, which meant that the test was geared for white women. And the tests, tests don't always actually tell you how good of a therapist someone's going to be. So now there's going to be an alternative pathway. We've joined an interstate compact for licensed professional clinical counselors and social workers so that if you meet these standards in this pact, any state that's part of the pact, you can practice in. And that also means that people in other states can practice in Minnesota if they're part of it as well. It also clarified the term clinical trainee. So what would happen is, say you were a clinical trainee, so you were doing your supervision hours, then you were done with your supervision hours, but you were waiting for your test results. You couldn't bill. And that was just, kind of weird. So we made it now it's all seamless and people won't have a problem. We created a program for supervision in rural Minnesota. Actually, we created a program for supervision so that, say you could give money to a community mental health clinic and then anyone who had 25% of Medicaid or more, and then you could actually pay for that supervisor's time so that you could offer the supervision hours for free for that clinical trainee, because we know paying for supervision is another barrier to getting licensed. We just needed to clarify that we always intended it for also to be targeted for rural Minnesota. So that should help in the future. Some other things is that now there's going to be an advisory committee for direct care and treatment, state-operated services. They're now moving to be their own agency, which we support. We never thought it made sense in the Department of Human Services to provide, fund, and oversee and license all under one agency. There needed to be kind of a separation there to make sure that, especially for licensure, that we were making sure that they were following things. There is a guardianship task force to look at how can we reduce the number of people under guardianship and move to some other models. And then this we always thought we had. So in the statute it said that we were going to have an assistant commissioner over mental health. And then a couple of years ago they moved it to, even though it was statutorily the same, they moved it so that that person was also over housing and disability services, which meant we didn't have as much time focused on mental health. As you know, they changed the name from mental health and substance use disorder to behavioral health, which NAMI disagreed with because these aren't behaviors, they're symptoms, but we lost that battle. But now we're back to having an assistant commissioner only over behavioral health and not those other services. I just met with our new assistant commissioner last week, and so she will have more time to focus, frankly, on mental health. And then the Human Rights Act was changed to include impairments that are episodic or in remission, which actually will help a lot of people with mental illnesses because, you know, sometimes your crises, right, they're episodic. And sometimes people are in recovery. And then all of a sudden you don't have those same protections under the human rights law. So that's what happened this session. I know it was a lot. If you wanted like the full details, I have them here, 20-some pages. It's up here if you really want to look at all of it. But, you know, a lot happens every year, and it happens, frankly, because of your voices, because you share your stories, you call your legislators. The voluntary engagement, you know, targeted to Otter Tail was because Senator Rasmussen heard from a constituent about how something like this would have helped her family. So don't ever think that your voice doesn't matter. It absolutely does. I wanted, because I have, like maybe a few more minutes left? I've got 1 minute? Okay. So here you can just look what we're going to look at next session. We're going to look at rates. We got to keep doing that. Workforce. We need to keep expanding our workforce so we can meet the increased needs in our state. We need to look at our children's mental health system. We also want to update some of the language. Emotional disturbance is a horrible term to use. Let's just call it mental illness, right? We want to make sure we have employment. I know, you know, we've got IPS providers up here who do a wonderful job. They need more money. We need to look at access to housing, including looking at the sober home issue, and then just streamlining the process for people to become mental health providers. So it's a lot. You know, we do a weekly legislative update. You can sign up through our website and you can learn more than you ever wanted to about what's happening on the state and federal level. But especially during the legislative session, we're going to tell you what bills are up and when you need to call. So I'd really encourage you to do that. So now I think we're going to move on to the next segment of our program, and we're going to invite up our legislators.